All right, I think we'll get started if everyone is ready. I'll open with a whakatauki. Whakataka te hau ki te uru, whakataka te hau ki te tonga, kia mā kina kina ki uta, kia mā taratara ki tai, e hiake ana te atakura, he tiho, he huka, he hauhu, tihe Maori ora. So very warm welcome to all of you who are joining us and to those who are returning, to those who actually joined us for the first webinar as well. Kia ora, everyone. My name is Andrea. A lot of you will know me by now. I have done quite a number of webinars with the PSA over the past couple of years. This current one is part of a series that we are currently doing together with the transition unit. And we have done one webinar last month, which gave us a bit of an overview of the health reforms. And today we are going to talk about a couple of specific elements of the reforms, and that is the health charter and the health plan. And as always, I've invited a few guests. As you can see, I will introduce them in a minute. The purpose of the webinar is to just share the latest information that we have on the health reforms that were announced in April this year by Minister Little. It's also a wonderful opportunity for you to ask your questions. And I know that some of you have forwarded some questions in advance. So thank you so much for those. And I will bring them into our conversations as we go. So how are we running the webinar today? For those who are returning, you will be familiar with it. We'll do a round of introduction at the beginning, and then my guests will present, give you a bit of an overview of what's going on in terms of the health charter and the health plan. And then we'll have a conversation about it. And I would like to encourage you all to use the question and answer function to post your questions, and please keep them short and succinct, and I will bring them into our conversation. As always, one of our special features of these webinars is to get all of your questions answered, even though we might not get to them during the webinar. Last time we did the same, and you will receive the answered questions. There were many questions actually last time. So you will receive them very soon via email. We'll post them out for you. So please use the question and answer function to ask any question you might have. So, and another one, I would like to just remind you that there is the official website now for the health reforms, which has a lot of useful information about the reforms as such, about the Pai Ora Healthy Futures Bill, for instance, but also about issues related to the workforce. So I'll encourage you all to check out the website. Emma just posted it in the chat function, so please have a look around there. It's a very useful website. And of course, keep an eye on our PSA website and on our social media, where we have all the recordings and the presentations available for you to share with colleagues, friends, and family and whānau. So without further ado, let's introduce our guests. Today we have David Geller, Helene Carbonato, and Anna Marie Ruhr. So I would like to invite you to introduce yourselves and just briefly to our participants before we start the presentation and then our conversation about the health charter and health plan. Who would like to start?
I think it should
Kia
be.
I'll start. Kia ora, everyone. Helene Carbonato, thank you for inviting me to this webinar. I'm leading the commissioning work stream within the transition unit, and my background is a mix of kind of commissioning roles across district health boards. I've led and managed health services and district health boards. I've worked in PHOs, but my main background is actually a criminal justice background, and got into health in a very strange back-end way. And here I am, 20 years in senior management roles across health. So it's lovely to be here.
Wonderful, Helene. Thank you so much. Anna Marie, do you want to go next?
Kia ora, Andrea. Thank you. Ko te auhau te maunga, ko māpere te roto, ko parawhenua te marae. Ko Ngāti Hineira, te uri taniwha, Ngāti Korohui ngā hapu, ko Ngāpui te iwi, ko Anna Marie Ruhe Takuingoa. Kia ora, tēnā koutou katoa. I'm really looking forward to the kōrero today, and thank you for inviting me along. I've been in the health sector working for NGOs, PHOs and DHBs in the Ministry of Health for, gosh, over 20 years now. And currently I'm the Chief Advisor Equity in the Health Workforce Directorate at the Ministry of Health, and I've come across to the Transition Unit to be the Program Manager for the development of the New Zealand Health Charter. One of the key things for me as a young girl entering the health sector is I really wanted to be in health because I wanted to make a difference, and I wanted to create and be part of creating a health sector that was going to be positive for my daughter and my mokos and my whānau, because I've seen the impact of how a health system that doesn't work has truly impacted on my whānau and my family. Because there is only just me, my brother and my mokos and my girl. So yeah, that's why I'm here, and that's why I really want to make a difference, and I really look forward to the kōrero today. Kia ora koutou.
Kia ora. Great, thank you. David.
Thanks, Andrea. Kia ora. Thanks for making the time today. My name's David Galla. I suppose, look, I grew up in Wellington. My parents were Polish Jewish refugees, actually, came to New Zealand somewhat strangely and differently and separately in the late 1940s and early 1950s. And I grew up there, went to school there, ended up being a bus driver there, actually. But, you know, clearly the son of immigrants, you know, I had to do better. So I ended up at medical school, you know, and became an intensive care doctor eventually after working in New Zealand and England for a long time, and worked at Middlemore Hospital as an intensive care doctor for 31 years. And what was really interesting about working in that community was that it became pretty clear to me the results of what we got, despite the best efforts that we had, everything that we could do, it was much more related to the nature of that particular person, you know, so their sort of basic level of health and well-being was so determinative as to how well they did, despite you know, really good services from us, you know, that actually their ultimate result was determined by who they were, you know, and so many of those factors are determined by things outside of health. And during that career of mine, I became incredibly interested in those societal determinants of health and well-being, actually. And I'm on the board of Health Coalition Aotearoa with Boyd Swinburne, and I'm kind of really interested in sort of introducing evidence-based policies to reduce harm from things like alcohol, tobacco, unhealthy food, and to actually reshape the communities in which, help people reshape the communities in which they live to suit them, to give them the best opportunity to thrive and do well. And so it's a kind of an odd thing for an intensive care doctor to have that view, but that's my view. I've been with the Transition Unit since June. I had retired from Middlemore on the 1st of April, great day, and actually tuned into the parliamentary announcement of the health reforms in April, and was strangely moved by them, actually, when the ministers spoke. You know, they spoke very personally, and I was quite taken with that, and the boldness of the aspiration of this reform really struck me as well, and I'm kind of really excited to be part of it. And I'm working with this great group of people. I'm in the charter team, I'm with the plan, very involved in the carbon reduction program that we're just taken on board in the health plan, and a little bit of public health stuff as well. So it's great to be here, so thanks for the invitation.
Wonderful. Thank you all so much for making the time to, be here, share information, answer questions of our members. It's really greatly appreciated. And thanks also for sharing a little bit of your background. It's really interesting. So I think we'll probably start with the presentation. And I will share the screen with everyone. And then we can get started. It disappeared. Can you, oops. There we go. So I imagine that's visible now. Please, go ahead. The floor is yours.
Andrea, are you controlling this one?
I am indeed, yes.
Great. Do you want to move to the next one? Wonderful. So one of the things we wanted to talk with you about today was the development of the New Zealand Health Plan, which in the first 2 years will be an interim health plan. And the health plan is, in essence, the accountability document that government will hold with the two entities, and it will need to highlight how the two entities will meet te tiriti obligations under the sector reforms. It'll describe the kind of strategic context and the vision for the system. It'll have a strong focus on health inequities, and in particular for Māori, of course, as part of a treaty partnership requirements, but also for Pacifica people, disabled people, and we also have a strong focus on rural health inequities that are really strong in the system, and there hasn't been a very good and strong focus at a national level, at least from a rural health perspective. So we've got a rural health work stream as part of the plan. So in terms of developing this plan, we've got a number of working groups across healthy ageing, early years, rural health, mental health and addictions, as well as some hospital and specialist service work streams around acute care and planned care, and also describing what sort of the national and regional hospital networks might look like in the future. There's also a strong focus on population health and what we want from the system in the future from a population health perspective, noting that actually as a system, district health boards and the ministry have poorly focused and invested in population health services. And there's, as part of that population health view, a strong focus on intersectoral action and how we can drive that locally through these things called locality networks, which are part of the legislation and governments introduced as part of the sector reforms. So these work streams are, we've got working groups around each of them. They're tasked with identifying key priorities for the next 2 years for the entities to drive, and then a bit of a performance and monitoring framework around those actions that would hold the entities to account. Also, as part of the sector reforms and this interim health plan, there's a strong focus on what do we need to enable and think about differently from a workforce perspective. What do we need to think and plan for from a capital perspective, and what does data and digital need to look like differently in the future if we're going to enable these sector reforms to occur. And so this is an interim plan. It's a 2-year plan, and that'll give time for the entities over time to actually develop the fuller health plan, which will be a 3-year plan from 2024. In developing this health plan, we're engaging with numerous groups across the system. I think there's been over 200 engagements to date, and there will be a formal consultation process on the health plan probably around April next year. We'll incorporate the feedback from that process in May, and then we'll go to our entities with the draft final plan in June. And I'll just, if we can move, Andrea, to the next slide, which is a busy slide, but it's the last slide on this. And in essence, what we're trying to demonstrate here is that if we think about how we might plan and commission the health system in a different way, we're thinking about planning maybe in 5 different ways. One is around geographic boundaries. So what is it that we have to create in these sector reforms from a geographic perspective that drive things differently? And so in the legislation, there's a strong focus and role for the iwi Māori partnership boards, for instance, to have a say in what the needs of their whānau and communities are within the iwi, and drive those needs through the health plan through these things called localities. We're also very focused on thinking about how do the settings of health and well-being need to look differently in the future. So where might the settings of care be in people's homes, in residences, in localities, a strong focus on localities. And one of the things that we've seen in the feedback to date is people thinking that these reforms are about sort of nationalisation or a national view of the system, and what we're trying to design is much stronger national consistency in what is available, pathways, services, but also much stronger localisation where there's needs that need to be met at a local level. So there's a strong flavour of national, but also a strong focus on localities. Then we've got some work streams around sort of person and whānau centred care systems. So that's about health and wellbeing, kaumātua, rangatahi, early years. And then we're also thinking about, well, what needs to look universal? What, if you had a universal health system, what are the things that you can expect and should expect to be delivered irrespective of where you live? And those are things around sort of planned care, urgent care, cancer care. It shouldn't matter where you live, you should have access to a nationally consistent set of services. And then there's a very small group of services where we're saying actually these might need to be national health services, and these are things potentially like forensic and ID services, ambulance and trauma services. But actually there's quite a small group of these services in our thinking around planning. So that's that from a health plan perspective, and I think the way we're going to do it is we're going to keep going through the health charter bit, and then I think we're going to come back to questions at the end. I might have that wrong, Andrea, though, so please correct me if that's wrong.
That's all good. We'll move on to the charter. Anna-Marie, is that you or David who would like to take a turn?
Anna-Marie, I think why don't you, and we can do this a double act, but why don't you start?
Oops, we can't hear you, Anna-Marie. And you don't seem to be on mute.
Shall I start, Andrea, in that case?
You give it a go, and Anna-Marie can hopefully sort her technical issues there at her end. Thank you. David.
Okay, so he aha te mea nui o te ao, he tangata, he tangata, he tangata. Well, what's the most important thing in the world? It's people, it's people, it's people. And I think that those of you who heard the ministers speak at the announcement they made in the Grand Hall in Parliament in April would have got the flavour of this, I hope. They announced the structures, the enabling structures that took everyone a bit by surprise. Instead of reducing the number of district health boards to 12 or 8 or 4, as was recommended in the Simpson report, they surprised everybody by saying that we're going to create a whole new entity, and called Health New Zealand, that all 20 district health boards will fold into Health New Zealand on the 1st of July. They also, I think, surprised and pleased a lot of people by announcing the establishment of the Māori Health Authority with putia and resources to develop kaupapa Māori services to make a material impact on outcomes for Māori, and to develop a Māori workforce in time, and to connect with Māori populations in ways that we've failed to do in the past. They also announced some other structural changes around the Public Health Service, the Public Health Agency within the Ministry of Health, a refashioned Ministry of Health to look at policy and strategy and be a steward of the system, look at the performance of the Māori Health Authority and Health New Zealand, but to no longer be engaged in the delivery of services. And the establishment of a public health service, the amalgamation of the 12 public health units and a refashioning of their functions within Health New Zealand. So they were the structural changes, but the ministers were very clear too to point out that structures help or hinder, but it's actually people and how we behave and how we work together and how we engage with those that we're there to serve that will determine the success of these reforms. And, you know, before I go on to talk about the charter, and maybe if Anna Marie comes back, she hopefully can contribute too, but there are at least two significant pieces that have been signaled in the prior legislation that's before the House at the moment that point to, that will assist, I suppose, in the kind of drive, the kind of culture that we want to see develop over time. To really engage with those people who are closest to the delivery of services, to help shape those services to meet the needs of local populations, but also the outcomes of the reform. And those two groups are obviously our patients, the whānau and communities, and the other group is our workforce, it's you, and the teams that you work in and with and alongside. And there are two pieces of work that are signaled in that legislation, and they are the consumer patient whānau engagement framework and the health charter. I'll just deal with the first one first, actually, the consumer framework. I'll do that quite quickly. It's a piece of work.
You want me to move the slides?
I don't know that we've got a slide on that, actually, have we? I don't think we have. I've just inserted it in because I think it's important, Andrea. I hope that's okay.
That's absolutely awesome.
Yeah,
yes,
cool.
Go ahead.
Yeah, so the consumer framework actually is a piece of work being delivered by the Health Quality and Safety Commission together with the TU. And that really sort of starts to build on some of the really good work that's going on within the health sector and between the health sector and communities to actually develop a framework to assist all levels of the health service engage in a really meaningful way with patients, whānau, and communities to try and find a way to I suppose provide really easy access for that to occur in a reliable and regular way. And that piece of work will be is being worked up. It's on the Health Quality and Safety Commission website. It's worth taking a look at under the Partners in Care tab, and you can find out a bit more information about it there. That's an incredibly important piece of work. The other one is this one, the charter, and the charter is a means of actually lifting the voice of the healthcare workers, actually recognizing that it's through through the dialogue that occurs between and the relationships that occur between healthcare workers and between healthcare workers and communities that will determine the success of this reform. Given that we've got one employer from the 1st of July, largely Health New Zealand, some in the Māori Health Authority, but essentially one employer, it provides an opportunity for us to really work on the culture of collaboration and respect that we want, to reflect the kinds of workplace or improve the kinds of workplace relationships that value each of us, and for the contribution we make as individuals, for the contributions we make as teams, departments and organizations. And actually valuing the specific nature of that contribution, but also recognizing how it contributes to the greater good, to the outcomes of the reform itself that we want to see. And so a colleague in South Canterbury actually has described the charter as a korowai. you know, a cloak that envelops us in a common purpose. And the integrity and the mana of the cloak is related to the weave of the cloak, how it's put together and who puts it together. You know, the charter itself will bind together in this common purpose and be referred to in legislation, all of us. That will include the clinical and non-clinical staff within district health boards and outside of those district health boards today that are contracted by them. It will include the managers. It will include the executives. It will include the boards of Health New Zealand and the Māori Health Authority. And you know, it is through this kind of dialogue, the ongoing dialogue between ourselves as healthcare workers, our dialogue with our patients and their families and communities, within the sort of permissive structures that have been created, that we hope to strike the right balance between national consistency where that across areas where that's really appropriate, and local variation to meet the needs of local populations where that's appropriate. And that dialogue and that culture hopefully will continuously inform the models of care that are developed over time. And it will be those models of care that will that I would expect our managers to support, to budgets to fund, information to inform. And it'll be those models of care that I hope that will generate the kinds of performance indicators that are used for improvement, ongoing improvement. And it'll be those models of care that will inform workforce development over time. And so the reform's got a number of moving parts. It's got the enabling structures, the culture is the key to it, and how those two come together to inform the delivery, the health plan. You know, the interim health plan initially, and eventually over time, the plan for 2024, and how that plan changes over time. And, you know, I like to think about the end state here, and the end state is kind of like a network of services that span all the way through from the community where there are care services, social services. There's some impact there on environmental and lifestyle factors and how that networks into a local hospital, and how the local hospital networks back into that community, and how that local hospital is, the services within that local hospital are part of a regional network and a national network. So you end up with this matrix of services.
David, shall we just see if Anna Marie is
Yes, please,
back?
I'd love to. Yeah, cool.
Anna Marie, do you want to give it another go?
Oh, kia ora, can you hear me now?
Yes,
yeah, thank you, Anna Marie.
Oh, I'm so sorry about that. I don't know what was happening with the IT at this end. So where did we land on this? Have you spoken to this slide, David?
I have a little bit, but I think, you know, you've got a particular perspective on the charter that is so much richer than mine, Anna Marie. So, you know, I've talked about it, but please, you know.
Yeah. Oh, look, thank you, David, for great teamwork. Look, I guess I just want to reiterate that, you know, on the front slide, it really is about people. And that's what's so important and valuable about the New Zealand Health Charter. It really is a taonga. And, you know, this is a really huge opportunity for us. And I say us because I am one of those, I'm part of the workforce, to be able to contribute to and give feedback into what we think should be in the New Zealand Health Charter and see ourselves in that. And you know, we really want to hear your feedback around what the Health Charter means to you. So, you know, it comes back to the whakatauki, what's the most important thing in the world, and it's people. So if the next slide here is really just a snapshot of key milestones of what our timeframes look like, and once again, just reiterating that actually the engagement with yourselves, engaging with the sector, and making sure that we're doing that in a meaningful way to ensure that we've got as many pathways and access points to get feedback into the development of the Health Charter. Our time frame is, you know, we want to get all of the feedback by March. We'll start to draft up our the first draft, and our go live date is the 1st of July. So we've got a lot of work to do and a lot of engaging to do. And yeah, if we move on to the next slide. And just coming back to what I've been touching on is, you know, my job, our job as the Health Charter team is to really get out there and engage with you all, to hear your thoughts and ideas, and to really bring this to the table and influence, really influence, and you know, it's a once in a lifetime opportunity that not many of us get a chance to do. We always say that we want to be part of changing and influencing the health sector. You know, I've always been saying it. That's why I've been in the roles that I've been, because this is what I am advocating for in all of the roles that I do. So I want to be able to make sure that, you know, we hear your voice, and that we can bring your values, your principles, your behaviours, your thoughts, your feelings about what it's like, what you expect should be in that New Zealand Health Charter, and we're really keen to work with you to hear that. Thank you.
Kia ora. Thank you so much, Anna-Marie and David. I would just like to encourage the participants, if you have any ideas or if you can think of any values, principles or behaviors that should be included in the Health Charter, please post them in the chat and share them with the other participants, and we'll keep an eye on that. You will also, most of you will know that we are currently running a process internally at the PSA to get your input to our submission that we'll make on the Paeora Healthy Futures Bill, which will include the Health Charter, for instance. And I would like to use this opportunity as well to encourage you all to participate in this survey. But I think we'll get into some questions now, if that works for you. One of the first and probably most prominent questions that I hear pretty frequently in meetings with members, and there was also part of the questions that we received in advance, is how do we make it work? How is the Charter going to be implemented, and how who is responsible for implementing it? I think that's really important, because a lot of our members have charters in their workplace. They are not short of guidelines on how to do their work, and, you know, good value-based standards that guide their work. So how is this different, and how is it going to be implemented?
That's a really good question, Andrea. Shall I start, David? Helene? Sure. Look, so you know, the Health Charter gives effect to, so our entities are accountable to giving effect to the New Zealand Health Charter. So the Ministry of Health, Health NZ and the MHA are all responsible to give effect to the Health Charter. We, at a level at the moment, we're talking and discussing how we can make sure that that's implemented in the change process as we move forward, and what does that look like as we move forward in regards to the accountability mechanisms. But the opportunity going forward is also about working with our sector to get feedback on actually what are the other ways that we can make sure that there are levels of accountability that creates that line of sight. And that's the opportunity of continually working with our sector in that co-design approach, and having that open feedback around actually, you know, making sure that that's what we're doing in a robust way. You might want to add to that, David.
Yeah. Do you want to add?
Yeah, I think that that is a work in progress, I think. This is quite new for a health sector in New Zealand to have something like this at such a high level. Certainly mentioned in legislation, certainly will be part of the accountability mechanisms, I would expect, at every level within the new entities. How that's going to play out, we're going to have to wait and see. How that's going to be noticed by people like yourselves, ourselves, or people who are actually working at the coalface, that's going to be very interesting to see too. I think that one of the really important things about the power of something like the Charter is the expectation that it creates within us for what we expect of it. And that's the conversation that we really need to have. And that's what needs to be expressed, I think, in the Charter itself. It can't be all things to all people, but it's got to be some things to all people. And so, that's so getting down to the essence of what that actually is really this exercise. But actually, the practice of it, we've talked before actually with some of the other unions actually about, well, how do we know? How will we know whether or not this is being respected? What are the things that we would want to see, in our workplaces that would tell us that these things are actually happening? And we've talked about workshopping some of those things. We haven't actually organised anything like that. But, these are really important questions because it's a fabulous question and it's incredibly important. It can't just be a piece of paper that sits on the shelf. It can't be something that's stuck on the wall and no one pays attention to. It can't be just a tag on to the end of an email, like a values and value statement that no one sort of reads. It's got to be really real. So I think it's a work in progress actually. But there will be, but the entities are charged with it. It's in the legislation. So there will be this, and there will be various accountability mechanisms. But how effective they're going to be, I'm not entirely sure, and that's still a bit of a work in progress. Helene may want to contribute to that as well. I think to this conversation because it's a really important one.
I don't think I can add anything more on the Charter. I guess from a commissioning perspective, the way that we look at it is that we are going to have to create a whole set of new behaviours in the system, across the system. That's everyone from kind of people who work within the entities to our providers in the system to our iwi Māori partnership boards. We're all going to have to connect in a fundamentally different way to the way that we connect today, because in essence, everyone in these reforms are the same people. So there's got to be a circuit breaker in the way that everyone interfaces together if we're going to create something different with these reforms. And so some of the things that we've been thinking about from a commissioning perspective is kind of leadership, wānanga, programs, new grad programs, and that's across the system, not just for those that are employed within the entities, because we recognise that we're all going to have a new set of behaviours that don't currently exist in the main in our current system.
Yeah, I think you're touching on something really important there, Helene, in terms of commissioning in services that are publicly funded but privately delivered. Our members will have a strong interest in seeing those ones covered by the Charter as well, also to ensure better integration of services and the smooth delivery from start to end. And often it starts in the hospital and continues in the community. So yeah, that's really good to hear. We also had a few questions around tikanga Māori practices and healthcare and cultural competencies in general for the diversity of people that live in New Zealand and use the health system. So do you think that could be an aspect that might be included in the Charter? Would that be a useful aspect, or do you think it should sit elsewhere, or how would you answer that question?
If I could start that one, and please jump in at any time, David and Helene. but the development of the health charter is in partnership. And you know, there's a strong partnership approach to everything that we're doing within the TU and our approach, and particularly the New Zealand Health Charter, because this is about cultures, this is about how we work together, this is about principles, this is about everything that we've been working for so many years to see within our health system. So we are working really closely and really keen to work with our communities to ensure that the New Zealand Health Charter reflects what our workforce are telling us, and working alongside with a very strong Tiriti lens and foundation and principles supporting that and guiding that process.
Yeah, and then maybe if I can add that from a planning and commissioning perspective, you know, meeting Te Tiriti obligations means, again, a fundamentally different way to how services are commissioned in the future and what gets funded, and, you know, what are the options that become available for Māori in terms of service provision, what are the hauora models of care that we're going to fund and develop and implement, what's the research and evaluation methodologies that we'll use to understand what impacts some of our hauora services are doing, because we've got very kind of medical and treatment models in play. What sort of audit frameworks will we develop that support hauora models of care? And I guess the other thing is that a big part of the sector reforms are around improving population health approaches. So, you know, upstream investments, prevention, wellbeing, and our Māori partners have got a really strong interest and focus on that. So, you know, what are the sorts of services that we might fund in the system that have got a much stronger focus on prevention and wellbeing and tino rangatiratanga in terms of allowing Māori to self-determine the pathways and care that they've got. So certainly from a commissioning perspective, we're working closely with our hauora colleagues, and the iwi Māori partnership boards will have a definite interest in this too. So again, it's that step change. We can't think about these sector reforms and keep doing what we're doing. So we need to, from a commissioning perspective, think quite differently about how we address Te Tiriti obligations.
David.
Yeah, I might just add a little bit to that, to build on that, just to say that through that approach and what we learn from that approach, what the system learns from that approach and how it adjusts to meet the needs of Māori in ways that, you know, through that collaboration and through that genuine engagement, I think there are huge benefits for all New Zealanders actually, because that's the approach we want for everyone actually. Whether you're Muslim, whether you're, you know, from whatever background you are, these are services. These services need to meet people's needs, you know, and they need to be framed in ways that are that actually make a genuine connection with people to be effective. And so there is this piece about that engagement with, you know, patients, whānau, and communities that is, you know, that has got to be deep and meaningful and needs to, and, you know, that will develop over time. And I think that, you know, that's one of the huge benefits, I think, for the engagement we will have with Māori, with the system that will learn about, you know, how do we engage with Māori properly? What are the jewels there, you know, and actually the principles of that, I expect, will be of huge benefit to you.
Thank you. I would like to take it up a level now to the overall health system. We have a few questions around the different new entities and how they collaborate, how they work better together, and then also, of course, across or down towards the local level and community organizations. And I'm just wondering, the health charter, but also the health plan, they are key documents, I guess, as part of this health reform, and they will influence the different entities and probably guide them as well. So how do you see the charter and the health plan fit within that bigger structure, that bigger system, and how does it guide what we are doing in the future? A second question related to that would be how workers, and David touched on it a little bit before, how workers can actually participate within those frameworks to design and deliver the services that people living in New Zealand need and have a right to receive. What are your thoughts on that?
I might take the second one and I might leave the first one to David. I can add to it. But part of the thinking about commissioning and planning in a different way is the need for a much better understanding of health intelligence and people analytics. We do these things in district health boards called health needs analysis, and they tell us the same old thing that we know at a national level. You know, Māori die of cancer at twice the rate of non-Māori, and so forth. And we need far more granular information of what the experience is of different populations and communities as they go through health services at a local level. And so part of the design of the commissioning is working with whānau and communities and iwi Māori partnership boards who will actually have a statutory function to support that planning of need. So if we think about commissioning, there's a much greater focus on understanding need at a local, regional and national level, and that's in partnership with consumers and providers and experts in the system, which could be Māori providers, could be Māori evaluators and so on. And there's a strong focus on the design phase looking different. So, you know, again, there's a strong, I think, approach at the moment across commissioners. This is what we've designed. We're going to contract this. We're going to tell you how it's done, and then we're going to measure, often based on widgets. You know, we funded 10 things and you only gave us 8. And part of the commissioning framework that's been developed with our partners across in the Interim Māori Health Authority is how do we do that in partnership with communities, with providers, with consumers, so that we jointly design services that meet the needs of those populations. And again, that's a fundamental shift in skill base that a lot of the commissioners in the system haven't got. You know, ministry and district health boards, there are pockets of this, but not consistent. And so again, we're giving thought to how do you fundamentally change the behaviours of the commissioners in the system to design services in a different way. And that's where some of the work on kind of, you know, pai ora wānanga and or leadership institute and how do you get people to behave and work differently is being looked at. So there is a strong focus on service development that meets the needs of consumers and whānaus and providers and clinicians, all those that are in the system, to develop those things jointly. And David, you might want to sort of talk more about the national.
Yeah, I think that the reforms are called transformative reforms, and transformation is an interesting term because it's a term that relates to outcomes. And I think that in something as complicated as this, where there are so many moving parts, it's often quite useful when you get, you know, you can get lost in the weeds, you know, lost in the grass. You can sort of to actually come back and go back to what is it we're trying to achieve here? What are the outcomes that we actually want here and that we've all agreed are important? And, you know, and I think that that's going to be really important, a very important sort of focus for all of us in the system. And so if we think about some of those things, and I know that a number of members, well, many of you in the audience will have heard of those 5 key shifts about embracing the principles and obligations of Te Tiriti, comprehensive set of services close to home, equitable access to hospital and specialist services, how we use data and digital services, how we invest in data and digital to actually support healthcare workers to provide through, so we can provide networks of healthcare workers to support people close to their homes, but also actually provide data and digital services to people in their homes or in their localities and in their communities. And actually the fifth one is actually how do we value health and care workers and ensure that they're well trained. And I think that, you know, those are the kinds of outcomes that we're constantly wanting to come back to. And they are leadership functions within the system, actually. You know, and this is what we will expect from our leaders, to engage with our healthcare workforce, to have that dialogue, and for our healthcare workers to talk to populations, patients, whānau and communities. And that those dialogues are ongoing, and they continually shape the nature of our services. You know, in the work that we're doing on the plan, you know, and certainly in the hospital services, I mean, there are some wonderful examples already of workarounds that people are doing, you know, to ensure that they can provide quite specialized services in quite remote areas through workarounds in a dysfunctional system that makes it really difficult to do. And so we're learning from some of those networks now to try and think, what do we need to do? What could we do to actually strengthen those networks? How do we actually learn the lessons of those things and apply them elsewhere? You know, what are the other what are the other groups that who are out there who've got answers to these issues? And increasingly, we're sort of going to them and saying, well, how would you deal with this? You know, I mean, we've had some fabulous meetings with people who are coming to us with the solutions to things that are actually been really hard to solve. And that they've been really hard to solve because no one has asked in the past, or if they have asked, they haven't listened, you know. So, you know, the answers are there. You know, we just need to go out and actually have the conversations and actually then start about thinking about how do we actually allow those things to emerge and to flourish. So that's a process, Andrea, and that's going to take some time. And, you know, and Helene has talked about this shift in behaviors and competencies that we're going to need from our leaders. You know, and although yes, there will be quite a lot of, you know, people who will transition from one place to the next. Now we expect, and I think you should expect, a different form of leadership. You know, you should absolutely expect that. This can't be the same command and control sort of BS that we've had for the last 20 years. You know, we can't just have the same people who have, you know, sort of led that kind of, you know, inability to connect with people in a new job, pretending that they can. You know, that's not the way it should operate. And I think that we're looking to the population. We're looking to the CTU unions. We're looking to Apex to hold the system to account, to actually deliver on the things that you said that you would deliver on, and to behave in the ways that you have promised to behave, to allow these things to emerge, to develop the services that populations actually need and achieve the outcomes of the reforms. We have all got a really important role to play in holding the system to account. And, you know, and that's not a one-off thing. And that's a continuous engagement that we want and we need from all of you. There's a heartfelt plea.
If I could add to Helene and David's comments, you know, in regards to participation and voice, and how is this going to impact on the entities? Well, you know, the health charter and the health plan will guide the entities and their direction and strategy and their thinking as they're going forward. But if I take this back to actually the reality of what's going what's happening currently out in our sector, we've got some amazing initiatives across that are happening across the sector, across our regions. We've got some amazing iwi initiatives that are happening in our workforce spaces. We've got COVID, amazing examples of how our community, how our providers can mobilise and pivot in an environment of stress and hardship, and can just pivot because we know what's best for our people. And so all of these amazing initiatives, all of the work that we're doing out in the communities, all of these great initiatives are being raised. These are the things that are coming to the fore when we're talking about what works and what doesn't work. And so that's another mechanism, another avenue of awareness in regards to our health sector, saying these are the things that are working for our people. We need more of this. Yeah, so this is happening. This is happening right now. We're not waiting for the reform to have this happen. This is happening right now, and it is being heard. So there is that happening, and there's more of it. And when we move into the new space where we have our locality regions, there's less bureaucracy, and there are many mechanisms and pathways to be able to have a look at actually what works in the regions and the locality areas. And that's the point of difference of these localities. That's the strength and the opportunity, and we're already navigating in that space right now, and it's only going to improve as we move forward. Kia ora.
Kia ora. Thank you so much. This was a very rich conversation with lots of information and lots of ideas. And what I took away from it is that the attempt is there to really make the participation of workers across the health system an integral part of moving forward into the future of health. So thank you so much for outlining that and giving us the opportunity to ask questions. We actually have many more questions which were left unanswered. I can assure everyone your questions will be answered, and we'll post them out to you. And also Anna-Marie talked a little bit about localities at the end. So our next webinar on the health reforms will be about localities and how they can be used to meet local needs. So we will do that just before the break at the end, mid-end December, so in a couple of weeks' time. So please watch your inbox. You will receive an email invitation from us for that webinar. And if you liked our conversation today, as always, please share it with your friends and colleagues, family and whānau. The recording will also be made available on the PSA website and on social media, so you will receive a link to that as well. And yeah, I think there's probably not much more that I can add. We are also coming close to finish time, so I will just close us off with a whakatauki. And before I do that, just again, thank you very much for your time, for all your energy and your thinking that goes into this. So thank you very much. And we will definitely stay in touch and want to be involved going forward. Thank you. No te rauro, naku te rauro, ka ora ai te iwi. With your basket in my basket, the people will live. Thank you, everyone, and stay well.
Good, Andrea. Thanks to you and everyone. Thank you.
Akite.
Okay.